I'm the moderator today. My name is Matt Seymour. I'm the president of the Chicago Asthma Consortium. I'm also the executive director of Mobile Care Chicago, which is a nonprofit organization that uses RVs to travel around the city of Chicago and Lake County to provide free asthma and allergy care to people, particularly kids who have issues with access to follow-up care and medications. Next slide. Our schedule for today's meeting is, first of all, we'll do a quick overview of the Chicago Asthma Consortium and just what we're about. And then I'll introduce our speaker. I'm really excited to have him here. After that, Marc Rubin will do his presentation, and then we'll have a question and answer session at the end. And then we'll close promptly at 12:30. Next slide. A couple of housekeeping items. So first of all, as I said before, you can shut off your video and your audio. You won't need either during the webinar today. If you have any technical difficulties, you can contact Kay in the chat, or you can email info@chicagoasthma.org. We encourage people to network in the chat. So during the presentation or now, if you can just introduce yourself and say hello, tell us what organization you're from, or just what caught your interest about this particular presentation. That would be awesome. I'll also just sort of chat with folks throughout the presentation. If you have questions for the presenter, you can also put that in the chat, and I'll be monitoring it as we kind of go along. I'll aggregate all of the questions, and then I'll present them to Marc at the end in the Q&A session. We also have an evaluation survey at the end. So we'll put the link to that in the chat at the very end of the presentation. We really appreciate your feedback, and it helps us to make programming that is relevant to you, and to also just keep it in a format that you find engaging and that sort of meets the information you're looking for. So feel free to fill out the survey. We take it very seriously. And it'll help us make better programming. So next slide. Just a little bit about the Chicago Asthma Consortium. So our mission is to improve the quality of life for people with asthma. We do that through advocacy, education, and collaboration. And in particular, CAC for over 25 years now has been a convener for medical professionals, people in public health, business leaders, government agencies, community-based organizations, and individuals who have asthma or are passionate about helping get people with asthma access to education and resources, to convene all of those groups to raise awareness for this disease state and to improve the quality of life for people who live with asthma. If you want to learn more about us, you can go to our website, chicagoasthma.org. And next slide. You can also join one of our committees. So the Chicago Asthma Consortium is completely volunteer-led. So we have a board of directors that sort of helps to marshal all of the different committees that we have. And if you would like to volunteer within a committee, you can always reach out to the email address below, info@chicagoasthma.org, and one of the board members will correspond with you and will get you into the next meetings. We have a community advisory board that helps people to shape research projects that affect people with asthma. We have a community engagement group that provides direct education and resources to people who have asthma. We have a fundraising committee, a membership committee, and then a professional development committee, which puts on the forums like this one today. We are also accepting applications to join the board of directors. So if you're interested in joining the board, you can also contact info@chicagoasthma.org, and we can tell you how to apply. Next slide. And with that, it's my great pleasure to introduce today's presenter, Marc Rubin, who I've known for many years. So Marc is a retired pharmacist who worked in both hospital and retail pharmacies for many years. Marc was a certified asthma educator who has provided many trainings addressing environmental control as well as medication therapy for asthmatics. He was a past president of the Suburban Asthma Consortium and has been a member of the Chicago Asthma Consortium for many years. As a coach and director of safety for the Crystal Lake Soccer Federation, Marc mandated all coaches be trained in understanding asthma and how to respond properly should the need arise to maintain a safe environment for players. Currently, Marc is with the Asthma and Allergy in Older Adults Committee of the Quad AI, which he has developed, in which he has developed an exercise prescription for physicians to utilize for improving quality of life for the elderly population with medical issues like asthma. So it's my pleasure to introduce Marc Rubin, and I will turn it over to you, Marc, to get the presentation started. Thank you for being here.
And thank you, Matt. I greatly appreciate this. And let me get this clicked properly and going to the next part. Hold on, everyone. Want to get it to slideshow if I don't get these other things blocking me. And slideshow, the right one. Hold on, view. I love to have technology. Hold on 1 second. This is crazy. I apologize. View. I want the full screen. Hold on, folks. I'm almost there, unless you guys want to load it up. It worked a moment ago. This is nuts. Uh, can you load the whole presentation? Wait, slide master, reading view, slide sorter, normal. I don't understand because we did this earlier and it worked perfectly. View.
Yes, I will load it now, Mark.
Okay, wait, I think I got it. There we go. Sorry about that, folks. Okay. Anyway, Matt, thank you so much for the lead in. One of the things besides the asthma and allergy in older adults, the committee I've been in the longest is the Sports Exercise and Fitness Committee of Quad AI. And a number of members of the committee actually created the exercise-induced bronchospasm guidelines internationally a number of years ago. Now, moving on to this, assuring best asthma care. This is, I'm hoping that you will learn to benefit your students, your athletes, and your teams to make sure that they can perform at their best. And it's amazing that when a gym teacher goes to college to become in this area, they're not trained for the most part in asthma, epilepsy, or diabetes, which I find strange since they're responsible for the safety of these children on the field. So going to go through a number of things today. Dr. Andy Nish and I partnered on this initially. So what you're going to learn today is what is asthma specifically and the exercise-induced bronchoconstriction, which used to be known as exercise-induced asthma, except we've learned that it can affect anybody, which happened to me myself one time, whether or not you've got asthma. The different types of asthma triggers, and how to manage the asthma attacks. So, what is exercise-induced bronchoconstriction? It's a sudden narrowing of the airways, resulting in the shortness of breath. And what's happening is the muscles are contracting around the airways, where the person is going to feel their chest being tight, like they're being squeezed, wheezing because of the narrowness, and coughing in many cases. Most asthmatic students have exercise as only one of their triggers. So not all people with asthma can have this happen. It's usually when you get to a little higher level of exercise. But the exercise-induced bronchospasm can occur in anybody. It doesn't matter if you've got asthma or not. And what's interesting is a lot of times when you're dealing with students, some of them have never been diagnosed with asthma. And if they have this presentation during athletics, and they've not been diagnosed, they should really be evaluated by their physician. So what is it about the EIB, which is what we typically call it in the medical world, Generally occurs after 3 to 8 minutes of exercise in asthmatics, but it can even occur if you've only had exercise for a short amount of time and might occur 30 minutes afterwards. So it's not that specific. It's not truly defined. The only thing that sets off the bronchospasm is exercise. So it's these issues that take place, and a very critical factor that comes in has to do with drinking additional fluids before and during the activities. And it's critical to reduce the occurrence. If a person is going to be in a very long, intense event, it's like I'm a cyclist. I sometimes do 100-mile bike rides. You want to actually start the fluid loading the day before. You need to stay hydrated, and I'll explain why shortly. So, what is asthma? It's a chronic disease. It's an inflammation of the airways that makes it difficult to breathe. And the thing is, asthma is like a general term, and it's not like a specific thing. It varies person to person. It's not just one unique group of characteristics. So you can have variability as far as what might be triggering with the patient, when it's occurring, how you even treat it can be very individualized. So it's a label, but it really doesn't explain everything about what's happening with that individual person, which is where a diagnosis is critical. The typical symptoms are the coughing and the wheezing from the tightness, shortness of breath, and that hugging sensation of the tightness around the chest. Also, it's something that's going to occur symptomatically when a person is exhaling, they're having difficulty because there's a similar condition in presentation called vocal cord dysfunction, where the vocal cords close up and they can't inhale. So, like I was saying, the airway narrowing, you can see the airway muscles are constricting around, they're tightening around, and it used to be considered like spasm, but it's not a spasmy thing. It's actually where there's a constriction all the way around, tightening it up. From the inflammation, just like if you sprain your ankle, the tissue is swelling with more fluid, which also increases the tightness around the airway. And these patients also have an increase in mucus they produce in the airways, further plugging things up. So the common triggers, viruses, which is why you always want to make sure you're up to date in vaccines, exercise, emotions, which people wonder about, but laughing and crying can actually trigger an asthma attack. Now, allergens are compounds, typically proteins, that create the exaggerated response by the body. An irritant, almost like if you spill something in your hand, it gets all sore. That's a direct effect on the airway that is not involved with the immune system. Smoke, whether it's from someone smoking a cigarette or if you got a fireplace that's not ventilated, is a sample of that kind of a trigger. Indoors commonly are animal dander because people think, oh, I'm allergic to dogs. It's actually not even the dog hair, it's their dog skin. Cockroaches, rodents and their waste, dust mites. Your cleaning chemicals, there are a number of companies that actually make them that do not have the chemicals that can actually trigger with irritation. Perfumes again, and strong odors. So your outdoor allergens across, your mold and pollen vary by season. And it's usually tree pollen in the spring. Then you get grass, late spring, summer as it's evolving. And then in the fall, you get mold and ragweed is the typical. But it does vary on where you live in the country because the climate varies. So you've got different factors that come into play. The pollen's usually worst in the morning. Fresh cut lawn where you've got the blade whipping everything up in the air. The chemicals used for treating the lawn, as well as fertilizers and the weed killers, can be a trigger. Air pollution, especially, is more commonly an issue besides overall, if it's really bad, if you're living near highways or major thoroughfares with a lot of trucks with all the diesel particulates. Then your air quality generally is worse from late morning to early afternoon. It was also learned that in thunderstorms, a study out of Canada, that fresh smell we all smell when that electrical storm's moving in is actually ozone. So when you're coaching, if those storms are moving in, you want to get the kids out. Otherwise, you're putting the kids who may have asthma at greater risk. And with windy conditions, you might not live where it's a problem, but when there's strong winds coming out of the west, especially if it's farm country to the west, you've got all this dust and all these allergens being blown from miles away. So it's a great concern for everybody because it affects the kids with absenteeism where they're missing out in class. They're not getting the education that's being made up. The parents staying home to take care of them is work days lost by the parents. So it's not just the individual, it's their whole home and education and the parents that are involved with this. The medications is basically we're looking at what is done on a regular basis all the time, not for acute, um, where you go to the emergency room where they're going to give oral steroids in that. But this is for things controlled within the home environment. So your controllers are to keep the levels of inflammation down in the airways. They're generally taken every day, and there's no reason for them to leave the house. A lot of times they're like a once every 24 hours or maybe morning and evening. So they bring a stable level to the lungs. The quick relievers, which were always called rescue inhalers, they're bronchodilators, agents that open up and relax the muscles so the air is infused into it much more easily. And that way you can get back to feeling well again. It can be taken prior to exercise and sports that have triggered attacks in the past. Some people only have problem with having these occurrences take place when it's much more exertional sport than just, doing sit-ups or that sort of thing. Now, your primary is inhaled corticosteroids, and they reduce out the inflammation and the mucus production, creating a stable environment. Not all asthmatics have all year long, 12 months of the year. Some are just purely seasonal. So if you just have grass allergy, it's a good idea that you might first start the inhaled corticosteroids 6 weeks before the season begins, because even if you're in perfect control, there's always a low level of inflammation. So you want to be proactive and not reactive. So before you enter the season or the student enters it, they're already taking the inhaled steroid to keep things calm. Like I said, taking it home and the seasonal variation is very common. Like again, asthma is not one single condition. It varies person to person. People worry about the corticosteroids because all they think about is what weightlifters would illegally use to build up their muscles. Not related at all. And unlike the oral steroids that affect the entire body, the inhaled steroids are a much tinier dose and they're inhaled, so it's just truly affecting the lungs with minimal effect on the rest of the body. And below are some examples what you may come across. Now, where you've got the quick relievers that act within just a few minutes, then there is a category of long-acting bronchodilators. And they're used combined in the same inhaler. So double system that's in one inhaler, and it keeps the airways open from 12 to 24 hours, depending on the product. It allows lower dosing of the steroid because of the complementary effect. They are never used by itself without an inhaled steroid. The problem with overuse of these things, which I'll come to another point, if you overuse it, then the body adapts and becomes less effective with the medication. Nasal steroids, there are things called mast cells. Everybody has heard about histamine. There's another trigger called leukotrienes, and they line the sinuses. Well, their mast cells line the sinuses, And if the sinuses get inflamed and the person has asthma, it can actually trigger an asthma attack. So nasal allergies can trigger it, and things that change in the guidelines for treating allergic nasal issues used to be antihistamine first. Now the first step is actually the nasal steroids. You want to get the inflammation under control. Then the mast cell stabilizers, the most common many have heard of, is the Singular, the montelukast. It's generally taken into bedtime because our body functions sort of in the sense of a female has her reproductive cycle with her menses. Our body has cortisol as the baseline natural anti-inflammatory for our whole body, but it is not level all day long. It starts out low in the morning, it rises through the morning to the afternoon, and then a lot of times people in the afternoon have no problem with their breathing, whether it's COPD or asthma. But then again, in the evening, it starts dropping and overnight gets very low, which is where there can be the release of the chemicals, the leukotrienes that cause a person to wake up at night and wheeze. So it's typically taken as an add-on medication just at bedtime to reduce that risk. So getting to the general category of bronchodilators, where it opens up the airways by relaxing the muscles, it's for the tightness, it's for the wheezing and coughing that's taking place. It's also occasionally used for people with pneumonia, where they've got the chronic coughing. Again, they don't have asthma, but they get the inflammation. And with the new rules nationwide, students can have the albuterol rescue with them, the quick relievers with them on themselves, not in the nurse's office. They need to have it readily available. They also have to learn how to properly administer it because many people use them incorrectly. And it's not just the patients. Studies came out that 87% of healthcare providers don't know how to properly use them either, so the teachers fail, where it's critical to get to resources to learn the proper technique. They're generally taken 15 to 30 minutes before the exercise, where the effect lasts for hours, but they are not appropriate for team sports players as a pre-exercise treatment. It's fine for gym class a couple times a week, but like I briefly mentioned before, if they're taken constantly, the body builds up a barrier to it and becomes less and less effective, where it might not provide any rescue whatsoever. Below are the different agents. Ipratropium, some people have a genetic variation that these drugs don't work and they have to use ipratropium. So if they're getting a rescue that's not helping, they need to be reevaluated. So the goals that you have for children, the symptoms are gone. I mean, basically day to day, they are doing just fine. They're sleeping in the evening. There's no absences, and they can fully participate in sports. And some gym teachers feel that, oh, if they've got asthma, they can't. About 10 to 15% of pro athletes and Olympians have asthma. What you need is to ensure that these people coaching our children understand and can really work to build them up. My daughter was an asthmatic. She was in the travel soccer team playing midfield, which is the most strenuous of the positions. It's understanding what the condition is and how to address the issue to allow these children to be enabled to perform of what they desire, not being shut down. A major thing that should be very important for all, whether it's a teacher in general, but especially the gym teachers and the coaches. If a child has asthma, there is what's called the asthma action plan. And as you can see, there's a green zone, yellow zone for warning, red zone, serious. It has two evaluations. One is symptom-based, which you'll see on the left-hand side, and it tells you what medications they're on, how much they should be taking, and when. The yellow zone starts getting into what are you going to add on if they start providing symptoms that you're seeing. And then if you're not improving and you're in the red zone. Green zone is if they're performing with a peak flow meter. is from 80 to 100% of their personal best, which I'll discuss shortly. Yellow zone is when you're from 50% to 80% of normal, and that's where they should be off the field and they should be getting their medication to get them stabilized again. In fact, all these guidelines actually came out from Europe that because it was so prevalent there, that if you're on a soccer team or whatever, their version of football, of course, is the child does not go on, or the player does not go back on the field till they're back in the green zone. They have to recover. Red zone, that's emergency time. That's when you need to contact help 911, and you also have a higher level of dosing, which we'll cover in a moment. Now, the updated annually is the peak flow reading. And I'm hoping you can see this. This is a peak flow meter. I'll show you later. What this does, it gives the power of the breath going out. And because your lungs grow until your early 20s, every 6 months, they should be determining their personal best, which is done by, I always go by a winter break, summer break. And what it is you're taking the device, you inhale as deeply as you can, pulling the piece down, and you go, and I just blew 550. So on that basis, 20% would be about 425. So from 425 to that, I'm doing fine. If it drops between 425 and 250, now I need the inhaler. Below 250, I need more of the medication, possibly having 911 called. So to do the test, it's done about lunchtime when your cortisol is up and your inflammation is down, done 3 times daily for 2 weeks straight. The best number in that 2 weeks is the 100% point. That's where you determine 80% and 50% thereafter. And then 6 months later, you're repeating it again until they're about 22, 23 years of age. So, asthma in school, it's really important for the teachers and staff know who has asthma, but you do not have anybody on the first day of class or in the first week say, hey, if you've got asthma, raise your hand. The subject should be, nobody respond. I'm going to ask a question, but do not raise your hand. You do not want bullying that can occur if others find out someone else has asthma. And that's regardless if you're in elementary school or high school. You want them to privately meet you after class or send you an email to your address. And then you can offer communication with the parents. Get open communications for what their expectations are and letting them know that you know about asthma. So you've got that open communicate. See about having their asthma action plans, which, side note, I did mention, the action plan is created both with the physician and the patient. It's not created by the patient solely. It's a dialogue that takes place that is medically guided. Then to learn the signs of an impending attack, so you could see even on the field symptoms that catch your attention. Trouble speaking becomes worse the worse the asthma is, where they have a lot of difficulty even getting words out if it's very severe. Struggling to breathe, or they might be bending over. So what you have is for gym class and after school sports, because generally in the warmer weather, you're outside, you need a cell phone. The teacher needs a cell phone with them always in case of emergency. There are apps to make you aware of air quality and pollen levels and temperature that you can have just pollen.com email you every day automatically, put in your zip code. But there's also a couple of apps that are great called Daily Breath and Allergy Plus that are, again, very specific to where you're at to give you that additional knowledge. You might have plans for a baseball game outside, but the levels are very high. You schedule something else inside the gym. You don't go outside. You're putting all the kids at risk. And then you need yourself to know what the proper device technique is. And there's a lot of places and resources that are available. that actually the Chicago Asthma Consortium, I'm not sure if it's up already, but there is videos on the proper technique. So, assessment, the warning signs of an asthma attack. If it's mild, as we've discussed, it's the wheezing, tightness, short sentences, cough. When it's severe, those all worsen, but one thing towards the bottom, lifting shoulders while breathing is because using the muscles between the ribs to get the lungs to open up more. And if the lips are blue and the fingernails are blue, that means they're really in an extremely serious position that you've got to immediately address. This is no messing around whatsoever. That's 911. Immediately get help as quickly as possible. So you stop whenever the person you see is having some symptoms at all, get them out of the activity. Have them sit upright. Never have them lay down flat. You do not want the pressure of the belly resisting from the stomach, with the stomach from the lungs opening up deeply into the abdomen. Be very calm. Reassure the student you can help. You need that calmness, and one thing you tell them to do is slow their breathing. Just inhale, exhale. Take their time and do it with their eyes closed so they're not being stressed by what they're seeing around, and get the other students away. They should not be hovered all around because the emotions do play a part, as I mentioned. So you want to create a very calm environment that you can take control. And a lot of times, just that calmness with medication, within a matter of minutes, they're improving. Okay. So if you're outside, you want to have in your clipboard the action plans of the various children who have asthma. So you've got it right at hand. So you can review that and follow it completely. If you don't have it available and they're having the suffering, you have them take the puffs immediately, but each puff is spaced a minute apart. You want to give time for it to achieve there. Then you follow the progress and 911 if no improvement. If it's severe, again, 911 right off the bat, and you're increasing the dosing. You can repeat in 5 to 10 minutes until paramedics get there. Calling for help the severe cases, as I've covered. And after school sports, like I said, immediately available. Help all students participate. Make sure that they can all be a part. And if they have symptoms, not asthmatic, they should be evaluated. Monitoring the state, monitoring the person, having the peak flow updated so you know what the values are for them, and make sure they feel good enough they're in the green zone to resume. If they're moderate to severe, no more participation that day, even if they fully recover. So I already discussed this, the peak flow meter. As far as that, having a current asthma plan, their own quick reliever on site with them or with the coach on the sideline, their own breath holding spacer or chamber. On the right, you see the peak flow meter right there. The chamber is where the meter dose inhaler gets inserted in one side of it, and it's a one-way valve so they could slowly inhale and exhale, and the exhalation goes outside of the chamber. And an important thing when you're dealing with meter dose inhalers, you do not inhale rapidly. It's a slow breath. And they talk about timing, which is baloney. If you've ever made a bubble bath, most people properly turn on the water and pour the soap into the moving stream of water. And that's how the medication is. You exhale, you shake the inhaler, exhale deeply first, put it to your mouth, slowly begin inhalation, and after beginning, then hit the puffer and continue through the entire time without stopping. It's also best if they're looking somewhat upright, like at a clock on the wall, to have the curvature of the airway such that it flows evenly down, not going at 90 degrees. Here's references, and should need contact. And I apologize for going on. There's just a lot of stuff that needed to be covered. So if there's any questions, let me stop the share. Sorry about that, Matt, for taking so long.
Oh, well, thank you very much, Mark, for your presentation. And we will keep just a couple minutes. If there are any questions that people have, you can put them in the chat, and I'll make sure that we ask them to Mark. I know a couple people had to drop off promptly at 12:30, but we will make sure that the recording is available to everyone afterward as well, if you want to
That,
go back through some of the slides.
that and also the
Um,
PowerPoint for the EIB that I gave you also for posting.
yes,
It goes to much, much more detail on that.
perfect. And for upcoming events, we have another Lunch and Learn next month on the findings of a white paper that we developed on administration of smart therapy. So essentially, the guidelines change in asthma medications that happened in December of 2022, which carried some pretty significant implications. Um, and then we also have a conference coming up on November 15th where representatives from the city of Chicago, the Cook County Department of Public Health, and the Illinois Department of Public Health will all be presenting on their most recent asthma data. This is only the second time in about 10 years that they've convened something like this, and we'll have an opportunity to hear from all three agencies at one time and then also have a debrief, facilitated conversation about the implications of those findings. So yeah, to stay tuned for the fall conference, and registration will be available on our website. It's totally free, so I would recommend that anyone who's interested go to the website and sign up for that conference. You can find more information at our events page at chicagoasthma.org. And again, I'd appreciate it if you would just fill out the survey, which is in the chat function. You can find the link for that. So with that, we'll end today's presentation. And thank you all for your attendance. Thank you again, Mark, for a really great presentation. And yeah, have a great day, everybody. We'll talk to you later.